This visualization maps the invisible highway beneath American healthcare. Every month, more than 1.5 billion medical documents cross this network. That volume comes from over 4,000 hospitals and 50,000 clinics quietly handing off emergency room summaries, lab results, and prescription histories in real time. While it functions as a national resource, it is not a centralized government database. There is no central server farm holding your medical records. Instead, the current system, known as Carequality, is decentralized. It operates as a web of private trust agreements, allowing competing corporate entities to securely query each other's local servers. For a decade, that private trust held the industry together, but the system's reliance on the honor system has reached a structural limit. Bad actors have discovered the network's blind spots, and the trust model is fracturing. The response is a total architectural rebuild. The industry is transitioning from the private trust framework to a heavily regulated, federally endorsed utility called TEFCA. Understanding the mechanics of this shift is the single most urgent priority for healthcare IT architects today. The network's governing authority is moving from private contracts to federal law. To understand the reason for this migration, we have to look at how competitors share data without a central referee. This framework relies on 3 distinct pillars. First is the legal pillar. Every connected organization signs a binding contract requiring them to share records for one specific reason: treating a patient. If a doctor asks for records to deliver care, you must respond. Second is the technical pillar. It establishes a shared standard language. When a large hospital system sends a file to a small rural clinic running different software, the incoming data parses cleanly on the receiving end. Third is the directory. This operates like a master address book containing over 100,000 endpoints, allowing clinical queries to accurately route across the country in under a second. These 3 rules enabled fierce corporate rivals, organizations that compete for patients, to safely exchange data. However, this system operated on passive trust. It assumed every query logged under the category of treatment was genuine, which created an exploitable surface area. That risk compounded as the network's technical capabilities expanded. Originally, the system only supported manual queries. A doctor had to actively open a chart and search for a record, assuming they knew exactly where to look. What came back was often an unstructured legacy format called a CCDA. Requesting an allergy check might result in a 40-page text document, requiring intense manual review. This matrix compares that legacy method with modern event-driven architecture. Today, an emergency room admission and trigger an automated push notification straight to a patient's primary care doctor. The automation extends to public health. Using electronic case reporting, or ECR, hospitals transmit data on communicable diseases directly to federal monitors, the moment a diagnosis is locked. The data arrives at the CDC without any clinical intervention. By January 2026, the US CDI version 3 mandate forces all connected systems to support broader data capture, including social determinants of health. These mandated standards and automated routing turn the infrastructure into an active clinical intelligence engine. As the data became richer, the incentive to acquire it grew. In 2024, the largest electronic record vendor in the country, Epic Systems, identified massive anomalies in records extracted by a younger vendor called Particle Health. This data flow illustrates the collapse of reciprocity. Particle's clients were extracting over 7 million records from the network, while contributing only 100,000 back. They achieved this volume using a directory exploit called On Behalf Of. This allowed a single entry in the directory to execute queries while pointing to hundreds of unverified organizations. Because the true identities were masked, verifying the legality of the requests became impossible. Epic alleged that instead of treating patients, third parties were mining data to screen people for class action legal claims. Particle rejected the accusation, arguing Epic was leveraging privacy concerns to choke off market competition. They filed an 81-page antitrust lawsuit, dragging the conflict into federal court. The exposure of this vulnerability triggered immediate alarm. Major hospital systems demanded federal regulators intervene to secure the data pipelines. The dispute ultimately proved that a fully decentralized interoperability network simply cannot self-regulate against bad actors who are using clever identity masking loopholes. To prevent massive hospitals from unplugging from the network entirely, Carequality deployed emergency governance reforms in 2025. This architecture maps out the delegation of authority policy. It replaces the on behalf of loophole with cryptographically proven chains linking every third-party application back to an authorized healthcare provider. They also move to active vetting. Organizations can no longer simply register and begin querying. Every node must pass a security audit before gaining access. Simultaneously, the definition of treatment was narrowed, removing the legal ambiguity that allowed data mining requests to slip through. Finally, the network accelerated dispute resolution, enabling connections with violating nodes to be severed in days rather than months. These patches stabilized the immediate crisis, but they also converted a cooperative framework into a heavily policed environment, exhausting the viability of private trust. The legal and technical stressors exposed by these disputes showed that private agreements could not resolve identity masking at scale. The current network's bounds were strained to their breaking point. The solution is the Trusted Exchange Framework and Common Agreement, known as TEFCA, which provides a permanent, federally endorsed architecture. Carequality has frozen new participant onboarding. Their sole strategic objective is now acting as a transitional bridge, migrating the private lattice onto the federal framework. Market forces are accelerating the shift. Epic Systems committed to migrating its entire customer base to TEFCA by the end of 2025, pulling the bulk of the industry's volume with it. Regional exchanges are also pivoting. Because the national data highways are now federally standardized, local exchanges are transforming into data utilities that handle city-level analytics. Under the TEFCA framework, Health Data Exchange functions as a regulated public utility. The commoditization of data routing changes the industry's business model. Digital health vendors must now pivot to selling clinical AI and analytics, built on top of the utility layer. Those new analytics engines are tasked with fixing a historically fragmented clinical experience. This data hierarchy demonstrates the impact of the modern FHIR standard on the point of care. It condenses 40-page text documents into exact, context-specific data points. Delivering a single required metric rather than a wall of text intercepts medication errors before they occur. For patients, the transition introduces computable consent. The patient's authorization dictates the technical boundaries of what moves through the network. Driven by updates to federal privacy rules, individuals can mask specific sensitive categories, like substance use or reproductive health, while allowing routine blood work and immunizations to travel unimpeded. The network no longer assumes permission by default. Authorization originates with the patient. The new foundation of American healthcare is an invisible, strictly regulated federal utility.